first panel here, or to one of these three panels which now follow. And in this panel, we are focusing on processes of resistance, of dissent, and also standardization in emerging fields of medicine research, and on the ways in which these processes relate to the influence of global asymmetries. And it is my pleasure to welcome in this panel Professor Roger Jeffrey from the University of Edinburgh, Jean Harrington from King's College London, Alex Faulkner from University of Sussex, Nicole Bauer from the University of Exeter, and of course John Dimoia, who is with us at least in spirit and with his voice on a recording, who has caught a serious flu and he couldn't come over from Singapore. Well, I think we shouldn't lose any more time and start immediately with the first presentation, and we listen to the recording of John Dimoia. And it's a 15 minutes talk. And so we can, unfortunately we cannot ask a lot of questions.
Good afternoon. My name is John Dimoia. I'm with the Department of History at LUS, and I am a visiting scholar at the Max Planck Institute for the History of Science between this year, 2014 and 2016. And the title of my presentation is Taking Samples, Historicizing the Biotech Narrative and the Formation of Regulatory Practice. This will focus specifically on two sites, South Korea and Singapore, and will focus roughly on about a 40 to 50 year mark between the early 1960s and the present. And in short, what I'm going to be arguing is that much of what we understand about the present last 15, 20 years for sort of cutting edge Asian biotech in these two sites needs to be understood in the larger historical context of their respective origins as newly independent nations in the case of Singapore from 1965 onwards, and as a very, very fledgling developmental state in the case of South Korea from the early 1960s onwards. So what makes a biotech story? That is, what is even biotech? Obviously, we could have a discussion about that, but I'm going to use the sort of US definition, which refers to specifically gene and tech and in the Bay Area, and specifically the commercialization in the mid-1970s of the E. coli and things like that. And this is a story that will be told in a forthcoming book by Dimoia next year that will be coming out from the University of Chicago Press. But so that's my baseline definition. What's different about the Asian story? We have a picture here of the Biopolis complex in Singapore. Part of the problem with getting at biotech in cases like Singapore and South Korea is that the economic success narrative is so deeply embedded within those two national contexts that it's very hard to even realize it's there. It's so deeply implicit. You have to sort of peel it away and try to look at what's going on underneath, and it's difficult to do so. Two, it's very hard to get to anything with a longer story because the recent story is so dominant. In the case of South Korea, certainly many scholars are familiar with the case of Wang Suk, and for Singapore, Biopolis, particularly since about the year 2000, tends to dominate the story. If we were to put that to a different set of actors, we could attribute the Singapore case to the Jurong Town Corporation, JTC, run by Philip Yeo, which put forth most of the investment money for Biopolis beginning in the early 2000s. Or in this case of South Korea, post-1997, Asian financial crisis, lots of government funds, but essentially a state-driven narrative. And JTC in the Singapore case also is technically sort of loosely state-driven. So it gets very hard to get away from these dominant economic narratives that are out there. And what I'm suggesting is that these narratives are useful, but they're very limited, in that they focus only on the present and they only tell us one particular part of the story. So looking at these two cases, what I'm hoping to suggest is that there are much more humble developmental origins or circumstances. And I don't want to go to any sort of simplistic cultural explanations, because that's, I think, what happened a lot when the Wang case came out. But I want to focus specifically on specific material and regulatory practices that emerge, and I'll go through the circumstances that underlie those circumstances. I'm also hoping to suggest an earlier context for regulatory practice in particular. That is, I'm not always going to argue for a direct link from biology. What I'll be looking at is very much more formative in terms of science. But in terms of how these circumstances in both cases formed an earlier context for regulatory practice, I think this explains a lot about why these two sites are very different, and in particular how these two sites might be very different from sort of more what we might call more metropolitan sites for things like stem cell research. So basically that's what I want to get at is these two simple take-home points, and I'm going to be walking you through briefly the South Korean and Singapore cases to try to make this argument and hopefully make it clear. Okay, now the South Korean case, we obviously could go back to the state's origin since 1948, but we're going to start in 1961 with the new administration of Park Chung-hee. He takes power in a military coup in 1961, and almost immediately he leaps upon health as one of the state's main initiatives. And what you see here in this image is a rat-catching exhibition in 1961. Now, this is not an accident. It's both metaphorical, that he's trying to chase out the rats. That's not accidental. He's trying to chase out his political opponents. But it's also literal. He does want to chase out the rats and clean up the streets. And you can see these posters which read, Tree Chop Cha, Let's Catch Rats. And this becomes very much an early sign of the Park Chung-hee state getting on board with public health and getting on board with medicine in that particular sense. Now, where this in particular starts to lead to what I will call changes in regulatory practice and in individual citizens' behavior is in the late 1960s, with the beginnings of the anti-parasite campaigns. This is a poster that reads Kisenchon Pangyo Hayo, Nekongkong Nega Chacha, and it's put forth by the Bogon Sawebu. This reads something along the lines of my health, I'm reading the second line, the line in white, my health, I find it. That is, my health, I am able to seize it. And what you see here is a young boy holding a bowl of rice in his left hand, and he's holding it above what seems to be a large snake, but which is not, which is in fact a giant roundworm, or technically known as the Ascaris longicoides. And this is a little bit disgusting, and it's meant to be. It's meant to be shocking. It's meant to remind you of one of the threats to your health. And literally in this case, the tapeworm, the giant roundworm, is trying to take the food out of his mouth. The boy is protecting it. And the state is saying, look, if you take control of your health, we will help you seize control. We will give you the power to do something about the situation. Now, the reason that many South Koreans had this problem was, of course, the lack of chemical fertilizer and the use of night soil, so that in a large agricultural nation, most people were consuming these parasites without realizing it and eating vegetables. So what the government did was they started targeting all secondary, middle, and high schools by 1969, plus annual campaigns. And what you would see here, as in this picture, is young school children going to the teacher's desk to drop off their little samples, their little specimens, and in this case, these are stool specimens. Now, what this means is that you've got an entire citizenry getting used to and participating on a particular level in terms of getting the state access to their body, in terms of giving the state access to their biological information. And that might not seem like a big deal, but what I'm trying to suggest is that in some ways, this will shape later behaviors in terms of how South Korea regulates these types of things. More importantly, South Korea needs new infrastructure. It doesn't have the capability of processing these samples at the mass national scale. So it gets assistance from Japan through OTCA, Overseas Technical Cooperation, and Japan sends things like the microscopes, like the optics that Korea needs. And then what South Korea also does is it trains a large corps of basically technicians, generally female, and I've had people point out to me that this labor is gendered, so I don't want to ignore that. It probably was. You'll see all these pictures, almost always the technicians are female. And these technicians were trained on the national scale to process these mass samples, look for parasites, record the numbers, and report these figures back to the government. So you do have, in many ways, much prior to the formation of a modern sort of biotech like Wong Sok, or sort of very cutting edge, you do have the formation of a biological research community here. I would argue it's granted a very different kind of biology, but again, this is what shapes the way that many South Koreans think about things like consent, how they think about biology, how they think about their own bodies, and access to the body is shaped by this period in the late 60s, as well as by things like family planning, which have similar effects. Just to keep making that point about the formation of a biological community, these are some of the images and posters that come from the campaigns. Again, in both the image on the left and the right, you see female technicians looking through microscopes. You see on the left the poster that reads Kisenchon Komchun, and I can't read the last part, but again, basically, searching for parasites, investigating for parasites, and you see the poster in the background with a magnifying glass. And the poster, which I didn't include, but which is also very famous from this time, reads Minyeon Dubonchik every year, 2 times, and famously has a very large picture of a microscope superimposed over the poster. So this idea of the microscope, of science, of the state having access to your body, and in particular, of having this take place in a national scale, this being all perfectly normal and well adjusted, very much dates to this late 1960s, early 1970s period of South Korean history. So just to give you an example, when people were surprised that female graduate students in Wong Wilson's lab donated their eggs, there was all kinds of questions about coercion and questions like that. I would again point to this much earlier period and behaviors like this and issues of consent. And again, also in the South Korean family planning campaigns, where the state had access to the bodies of its female citizens, and saying, look, these are actually continuous. In fact, these behaviors that appeared in the early 2000s were not at all unusual if you go back and look at the earlier history that formed the regulatory climate in which many South Koreans grew up. Okay. Having said that, similarly for Singapore, I want to make a similar argument that there's an earlier history that needs to be looked at. This is an image from a New York Times article taken from August 2006, and this was an article specifically promoting Singapore as a haven for stem cell researchers. This was the height of the Bush-era limitations on stem cell lines. This was appealing to people who wanted to get opportunities to go abroad and perhaps do stem cell research elsewhere. This was obviously in Singapore was very aggressively, and it still is, promoting itself as a site for cutting-edge science. So if we start with this image, again, we want to start, as with the Korean case, and look at the official sanctum story. And the official story that is out there is very much one promoted by JTC, the Japan Travel Corporation of former, I'm not sure if he's still CEO, but Philip. And the program of strategic investment put forth by GTC into the biological sciences since about the year 2000. And in particular, promoting things like liberal laws, trying to, that is, show outsiders that they have, by liberal laws, they don't mean, of course, that there's no, in fact, there's good governance, but at the same time, the laws are more flexible than those seen in the West, in particular, against the Bush-era stem cell line limitations. And seen as very much a haven, a space of art. That word haven, or hub, appeared frequently in both biopolis-related materials and in the stories covering the site. But I want to suggest, again, as with South Korea, that there is at least one alternative story, and this is the story of Arif Bongso, who is still, I believe, a senior professor at National University of Singapore, at National University Hospital, not that far away from where I am, and probably less than 15-20 minutes, and very much one of Singapore's first prominent researchers in this field, and still is, but certainly he lies outside of the traditional black story, so it's worth taking a little bit of a look at him and understanding how and why he adds something new to the story. Well, basically, we'll go like this, and I'll give you the short version of it. The longer version of it is, of course, in the paper. Bongso is recruited in the early to mid-1980s to join the ART program, the Assisted Reproductive Technology, otherwise we might call it an IVF program, at in vitro fertilization at National University Hospital. He's an expert in comparative mammalian embryology, and he basically helps to establish protocols for handling, storing, working with all kinds of tissues, particularly embryos, sometimes mammalian, but then increasingly human. And in doing so, what he does in many ways is establish protocols for the handling of these tissues, for storing embryos, for learning how long we can freeze them and how long we can keep them in a suitable environment. And many of these protocols will in fact establish the baselines for what will later become some of the the laws or the rules that govern stem cell research in a place like Singapore. So in many ways, he didn't necessarily know that he was establishing a precedent, but in fact he was. Now, his most famous result, and I've cited the paper here on the left, it's the citation on the left, Fertilization in Early Embryology. It's from Human Reproduction, 1994. It's Bongso and three others, and these three guys, Fong, Ratnam, and Bongso, almost always published together at this time. And what he was doing was working with co-culture and basically working with, technical term is, it's not human embryonic stem cells, he has another term for it. But in any case, he famously talked about how he was able to isolate these, it's inner cell mast cells. He was able to isolate these cells, and he referred to them as stem cell-like objects. Now, at the time, he saw this largely in the context of human fertility research, human reproductive research. He never claimed there was anything more. However, later, when Jimmy Thompson at the University of Wisconsin-Madison isolated human embryonic stem cell lines and was able to then sustain them, Bongso and others realized that what he had done was sort of a precursor step. Even if his inner cell mast cells from blastocysts only managed to, I think, replicate for like 1 or 2 generations. So Bongso was now frequently cited for this result, where he didn't do what Thompson did, but nonetheless he kind of did an important early step. And particularly people who wanted to challenge Thompson's patents in the 2000s sometimes would cite Bongso. But my point is that Bongso will become a very prominent stem cell researcher later on, but then doing this earlier work that he himself framed largely, almost entirely, as human reproductive or human fertility research, he set many of the protocols for what would become stem cell research in Singapore. And again, as in the South Korean case, you have this earlier model setting many of the tones and many of the regulatory practices for later biotech efforts. Again, the simple take-home point that biotech is not just about the present, it is very much about the earlier contexts, particularly these 2 national contexts in which it originates. Okay. So if I can summarize, and again, this is just a very brief version. I encourage and hope that people have a chance to read the entire longer paper, and I'd be love to answer questions about it, because I'm sure I'll have a chance to go back to it and revise and elaborate. But the practice of taking samples, whether it's, again, in the South Korean case, in anti-parasite campaigns, or in the case of Singapore, it's a small-scale ART IVF program, but nonetheless, it's coming out of a national family planning campaign. But these practices change the way that people behave. Issues like consent, participation, the storing and handling of tissues in the Singapore case, consent and participation, particularly in the Korean case, that this changes the way that citizens behave and gets them adapted to these new types of norms. As early as the 1960s in the case of South Korea, and certainly in the case of Singapore as early as the mid to early 1980s. And that this kind of mobilization, these campaigns, particularly more in the South Korean case, although both countries had family planning campaigns that were very active, get people used to the act of biological research in particular ways, that it prepares them to behave in different ways later on. In other words, there's a context for later efforts. When the so-called real biotech comes along later in the late 20th century, early 21st century, which it does. This is the Bible story, and this is the long story. You've already got many of the baseline practices and norms and sort of a context established by these earlier things. And again, all I'm really trying to suggest is that if we look at these earlier things, sometimes what looks to be anomalous behavior in a country that's sort of new to these practices, in fact, is very much consistent with what went on earlier if you look at it more carefully. So I will stop there. I want to thank very much for your attention, and I leave you with some last images of the anti-parasite campaigns in South Korea. Again, just to sort of hit home the historical point about looking back 40, 50 years to recognize how much this informs very much the context of the last 10 to 15 years, particularly when we're looking at biotech work. Thanks very much.
Well, thanks very much to all you. He cannot hear us, but he was so kind to present us his best use of electronic media. The good thing is we are perfectly on time, and we can immediately continue with our next speaker, which is Professor Roger Jeffrey, who is the sociology department, Professor of Sociology of South Asia at the Department of Sociology in Edinburgh, and is a long research and publication record that spans 4 decades. And in his recent years, in recent projects, he has been concerned particularly with issues related to health experimentation, public health, and the role of global inequalities in the regional context of India and South Asia. Thank you very much.
Thank you, Ashim. Particularly because I feel like an interloper, if not a fraud here, because the session is described, I brought it with me just to remind myself of how out of place I am. Resistance and alter standardization. And I have nothing to say whatsoever about resistance and alter standardization, I'm afraid. So, in a sense, my paper is about the non-alterity and the non-resistance that we discovered in research that we carried out in South Asia over the past 5 years or so. And it's, of course, a very different context from that which we've just heard about in Singapore and in South Korea. There are Indians here who don't need me to tell them, but the nature of the mass campaigns, mass mobilization campaigns that have been held in India don't have anything like the same feel and look as the campaigns that we heard about in South Korea. So the paper that I'm going to talk to, and I apologize to those of you who might have wished to see it in advance, I only managed to get it even to its current state yesterday morning, has a threefold structure. And what I'm asking in this paper, what we are asking, this is myself, Sala and Deepika, is what kinds of trials, what kinds of clinical trials are taking place, mostly in India. In fact, I'll talk almost entirely about India, but our research did cover Sri Lanka and Nepal as well. How did our interviewees view these trials? What was their take on it? And in this sense, I do have something to say to the title of the panel. The role of global asymmetries is something that I will be focusing on. And then thirdly, what kinds of threats are there to the science, as it's understood by these people, from the ethical context, from the scandals and the accusations that have been raised against the ways in which clinical trials have been carried out in India, and these that Margaret has already referred to, that took place over the last couple of years. But I'm going to start by saying that unlike Margaret and her team, we're not talking about bionetworks, we're talking about global assemblages. Whether that's a mistake or not is for you to discover and decide and tell me about afterwards. And global assemblages is a term that actually has multiple meanings. I'm just setting out some of them in this slide and the next slide. The focus of global assemblages really is about how actors in different parts of the world or in different parts of a particular part of the world come together across national boundaries, across territorial settings, but are no longer part of the national, this is Saskia Sassen's approach. In other words, that these stand outside national, but also very often international patterns, models of regulation and control. The anthropologists, Collier and I were on, talk about assemblages as being very amorphous in their structures. They're not always new, they don't reduce to single logics, and they shift. The formations that they take are varied according to what's at stake, particularly what is at stake in a particular context or a particular assemblage. And the assemblage, obviously, that I'm talking about here really is the clinical trial. So we can't actually really talk about clinical trials in India. We can only talk about the ways in which clinical trials manifest themselves amongst Indian participants. But the trial as an assemblage is the ones that I'm going to be talking about, are multi-sited trials with many participants in many different parts of the world doing many different things, all of which comes together at some point, usually in a report to the FDA or the EMA. So what we're looking at here is a kind of active network theory approach would be to say, to look at how things like pharmaceuticals or research protocols have agency, they travel, and as they travel they develop new social forms, particularly because they enter into very different local social institutions and processes. So the parts that constitute this social form are not dependent on it. The parts, what is a protocol, what is a clinical contract research organization, these have some autonomy from any particular trial, can be detached from it and reconstituted in other ways for other purposes. And for many people, this is just a kind of alternative way of seeing global capitalism. What else does global capitalism do? It sets up factories, it takes parts, it does all sorts of things together. And then includes within its activities things like regulatory practices, social structures, and knowledge formations. But it's also worth remembering that within this literature on assemblages, there are people who would argue that they can be emancipatory. They aren't necessarily just working to the interests of global capital. So that's a kind of very rapid run through a range of approaches to what global assemblages is. And if you want me to say exactly our particular take on that, you'll have to ask me another time, because I'm not quite sure I can answer that question. but you see the content, the field from which we're coming anyway. So in the case of India, particularly, there is offshoring or outsourcing of clinical trials from the 1990s onwards, at the time when Adriana Petrina and others talked about how trials were beginning to be outsourced from the familiar settings of North America, Europe, Western Europe, and Japan, and so on. And clearly the attraction for companies wishing to run such trials are well known: low personnel costs, large numbers of potential trial participants, many of them treatment naive, and opportunities to use trials to build market access for drugs that might emerge from or might be tested in these trials. And all of this speeds up in India from 2005 when the legislation changes, part of the process of signing up to WTO and TRIPS. But I think what's one thing that's very important to note about that account is that it's very much the account of the industry. So if you look at a lot of these sources, the industry says how wonderful it is to do clinical trials in India, how everything is going to be fantastic, it's going to be so cheap, we've got these wonderful trained in English clinical staff and so on, and off we go, the future is wonderful, and so you get predictions of massive growth in the clinical trial earnings for India in terms of foreign exchange. But I think it's worth remembering the things that have come much more to the fore in the last 5 or 6 years, which is that, of course, the FDA is likely to accuse other countries, it works within a body of knowledge and understanding which is very much, if not racist, certainly tends to assume that other places don't have the same ethical standards as it does, and then to be very skeptical about the quality of findings. And the structures, the local social institutions aren't necessarily rapidly brought into play to make possible the kinds of trials that people want to run. I mean, a clinical trial is designed to remove culture, politics, economy, everything except the body. And of course, you can't remove the body from all of that very easily. So, many of the expectations of rapid growth and the great benefits of doing trials in the BRICS, in this case, turn out to be rather less substantial. Here's a recent reference to a study which I don't think has been published, which suggests that India, you get actually relatively slow compared to Russia or China approvals, and you get large numbers of dropouts, and that's not very helpful if you're running a trial. So there are lots of problems that emerge from local social context which make trials more difficult to manage. So what are the trials that do get onto the Clinical Trials Register of India? And that's a very important point, because we don't obviously know anything at all very much about the trials that are not registered on CTRI. And here's an analysis of the 1,400 or so trials that were registered in 2011 and 2012. And I think one of the things that's quite interesting in terms of Ashim's point, I think this morning, was that, sorry, you don't have to wake up, it's all right, go back to the report. But the randomized control trials, multiple arm trials, and so on, aren't necessarily the only ones that are taking place at all. And in fact, for a large number of trials, we don't know, they don't report, data evidence is very limited. And even for the ones that we do know about, non-randomized trials account for about 20% of the total that are registered. As I say, there's another 15 or 18% about which we don't know. And the form of randomization is quite varied. So yes, there is a commitment to the randomized controlled trial as the gold standard, but it's by no means universal. That, I suppose, is the take-home message in this case. The point that is made about these trials and their effects, this is the global asymmetries, is that Indian trial sites and Indian PIs Indian trials, the Indian part of, particularly of multi-sited trials, is that they aren't actually very central to the processes that the clinical trial managers are interested in. So there's a series of sources here that I've managed to put together which talk about how even as late as 2010 or 2011, the dominance of US, German, UK, Canadian researchers in terms of publications, or of patients in terms of pivotal trials submitted to the EMA, and indeed for R&D offshore outsourcing for big pharma, remain very heavily within the control of the usual suspects. And the control in these trials, in this very asymmetric context, is, at least for several researchers, very heavily within the sponsors who develop the phase one, they develop the idea of a new chemical entity, and then they set the protocols, they do all the key scientific work before it gets anywhere near somewhere like India. And that what the Indians are doing, therefore, is very much within the context of a set of taken for granted rules of the game over which they have very little control. So Joseph argues on the basis of an important piece by Abrol et al. That the liberalisation of foreign investment has opened the door for outsourcing of clinical trials rather than to new investment on R&D from basic stages for the development of new drugs for Indian companies. And I think that's, you can challenge that if you like, but it's certainly, as far as one can see so far, a reasonable way of summarising this. So we're now turning to the research, some aspects of the research that we undertook between 2009 and 2011 in India, Sri Lanka, and Nepal. And I'm really just going to give you a little glimpse, some glimpses of the kinds of responses that people had to being involved in this industry as Indian participants and what it meant to them. And this is, this is the reference to trial coolies or trial sabs is from a paper on cyber coolies and cyber sabs from 2003. What's happening to the IT industry in India? Are they really becoming the people in charge, or are they just doing the grunt work? And certainly this is somebody who's looked at what's going on and says that they're not doing research. There is no real research taking place in India, he says. This is an academic perspective on things. It's just a service economy for other people. Dreadful. How do people respond to the opportunities that are provided to them by the arrival of these trial activities in India? Well, clearly it enables actors, I introduced the donor agencies here because part of our research was on public health experimentation, to translate their power, their economic power, the fact that they have the money for this, into symbolic and cultural capital to use to bring other people into a sphere of activity which they essentially control, and allows researchers and knowledge brokers within India to translate their cultural capital into economic capital. Some of you may recognize the references to Bourdieu. The collaborative relationships that develop in this kind of context are not ones that routinely transmute into equalizing or equal benefits. So there are some examples from our interviews, mostly in public health trials, where long-term collaborations between researchers, public health researchers in the UK or in the US, or mostly in the UK and the US, this is an English medium activity, have been developed over the years, and the researchers within India feel themselves to be on an equal basis with their foreign partners. But this is an unusual, relatively, it's a very much a minority finding. However, if we were to stop at that point, we would miss the possibilities of creativity, of emergent opportunities that arise from this kind of setting, and we would argue that it's not possible to say at this stage that those emergent opportunities don't actually take place. But there are a number of problems that people talk about when they say, well, how can we develop a research culture in India that models itself on what they see as the ideal research cultures, which they observe, again, in the English language world, mostly in the US and Canada and the UK and Australia and so on. And here's an example of a clinical pharmacologist who basically says that the research that they do is purely for money or else as a minimum requirement to get what they need for promotion. If you have to fight for a particular position, maybe your complications will count. But that happens so few and far between. Most academics are promoted on just a kind of routine basis. So in a context where there is no publish or perish setting, then the involvement in research has a very different characteristic. And there is, what I want to point to particularly here is the role of ambivalence, so that at some level people sign up to the notion of a research culture that is an aspiration, it's an ideal, it's something which people think exists, even if for many people this is misleading. But there's a very, in a number of the interviews, there's a considerable underlying thread of ambivalence, and this really comes in the last sentence of this. Yes, it's an open system, no, it's not threatening, everything's on the web, but I feel heavy as a person because essentially we aren't doing anything but other than dealing with kind of guinea pigs. Now, the ethical issues, I'm going to stop in a couple of minutes, are very much the context within which we were carrying out our interviews, and certainly have become much more significant since then. So there's a series of concerns about the ways in which trials are managed in India, which have been raised by civil society organisations of various kinds over a reasonably long period, since about 2007, 2008 onwards, but have become much more prominent because of the support from a joint parliamentary committee, 59th report of the Health Committee, which really drew attention to a number of things. But actually what they focus on are the minutiae, the small things. So they're focusing on informed consent. A number of reports suggested that the consent was not informed and free and fair, that other people were signing, that people in very weak positions were being involved in clinical trials, or they are concerned with a series of things that are at that level. Are the ethical committees independent? Are they well trained? Etc., etc. What is not being picked up very often, but here's somebody who really does pick it up, is the sense that of post-trial access. How can you have post-trial access in a society where nobody is going to be able to afford the drugs that are being tested? Okay, so by way of a conclusion, because as I say, this is a very drafty paper, and if anybody wants to cite it, I will come around with a hatchet and cut their heads off. We do have to understand these trials as subject to very substantial global pressures. The assemblage is a global assemblage, and the powers within that assemblage are very asymmetrical. Researchers have to deal not only with those global pressures, but also with a series of local contexts, parliament, regulators, advocacy groups, and they, as it were, usually retreat into or are forced into a situation where they just follow the protocol. They do what other people tell them to do, and don't think more widely about what's involved. When they do think, they get a bit ambivalent and uncertain about whether it's moral and ethical, what they're doing, how marginal they are, and what they can do about it. But none of the interviews that we undertook really suggests that has been turned into a set of alterity or resistance discourses. People aren't talking about how we need to do it different ways. So for all that Margaret talked about a very large area of grey, here's a lot of people who don't see much grey, who see black and white. Either we do it the way we're told to do it, or we don't do it at all. But whether the overall picture ends up as being essentially extractive or an emergent system that will allow, in the foreseeable future, an Indian kind of science, I think is very much an open question. There we go.
So thank you very much. We have now maybe 3 minutes for discussion, and I think it's best to really focus on questions for clarification, and any longer, more substantial question could be addressed later on. So who has any issues or questions? Please.
Just a quick question about that last quote, I guess. The 1,500 people died in trials in 3 years. Did you get evidence for that, or is that just?
Oh, there's no evidence. This is a civil society claim that is used. So people who were registered on trials may or may not have died. But whether they, even the most intensively studied trials, this is the HPV vaccine trials, which involved tribal girls who seem to have had their consent was given by the wardens of the hostels, all sorts of ethical issues. But I think there were a dozen of these girls who died, and they'd been raked over twice by different kinds of investigations. And you can believe Kaushik Sundararajan and say that actually the chances are that several of them were due to the trial, or you can believe the official investigation which says they had no relationship whatever to the trial. I mean, it's a completely incoherent situation.
So there's no official figures about it.
I mean, there's pharmacovigilance in India is almost inconsistent, I'm afraid.
So are there any other questions?
No, you're obviously referring to drug trials, I mean
Yes.
medicines, yeah?
Let me, sorry, just to be precise. We're talking about trials registered with the Clinical Trials Registry of India. If it's not registered there, we don't know about it. But it doesn't mean only drug trials, because lots of other things are registered.
It doesn't include cell therapy trials, for example, because that, a lot of what you mentioned is not necessarily true. It's exactly the reverse. There's a lot of cell therapy studies going on in India right now, where we actually have people from, the Western countries coming to understand the protocols and taking them there. It's the reverse now. It's not that we are following what's happening there. It's people in the developed countries coming and trying to adopt our protocols. So I think we need to make a distinction. Drug trials run by multinational corporations to get their drugs approved is a completely different thing. It's driven purely by commerce. It's driven by nothing else. It's what the drug companies do trials only because they want to make money. It's not research at all. All right? It's business development. Now, cell therapy on the other hand and other research is a different ballgame.
Yeah,
so we need to make that distinction.
I'm not talking about cell therapy at all.
Yeah, okay.
So thank you very much. One last question, please, and then we should continue to the next speakers, otherwise we run out of time.
I actually agree with Dr. Alok Sharma. I would like to ask you how many interviews you conducted, number one.
377.
Okay. And number two was, what did you mean by the Indian kind of science?
What I meant by the Indian kind of science was the kinds of things he talked about, the emergence of a more egalitarian understanding of what science might mean. So for most of the literature on this kind of field, what you get is the assumption that there is only one kind of science. And it is what Western countries have developed over the last 150 years, and it will continue in that kind of way. And all I'm saying really is that if that's the case, then the opportunities for Indian input into how trials might be organized, or the development of an autonomous, independent Indian research capacity in drug development would be very limited. And I'm just saying that I don't think we should assume that it's as limited as that. I think you could argue that this is something that's emerging over the last 7 to 10 years. And of course, we haven't seen yet what might come out of it.
Okay, so thank you very much, Roger. Everything else can be addressed later on again if there are remaining questions. I'm very pleased to invite our next speaker, Dr. Alex Faulkner, who is a reader here at the University of Sussex, Department of International Relations. He is a sociologist specializing in biomedicine and biomedical technology, and is currently the PI and co-PI of various research projects. He's presenting some insights of his current and recent research on the regulatory situation for stem cell and cell-based research in the context of Europe and the UK.
Thanks very much, Akim. Can you just
Oh, yeah,
disentangle my... hold on.
This whole neck, thing is here slightly different than normal due to the interface. Double click and it should work. And then use this button here. And then
Right, thanks Akim, thanks for the invitation to talk at this conference today. I was just reflecting, Roger's talk was about lack of resistance to a dominant paradigm. This talk is perhaps about a form of internalised coping with resistance in a very different setting, primarily in the UK, but inevitably within a broader regional and global context. What I want to do is talk about what I've called today gatekeeping rather than regulation, and gatekeeping in two fairly distinct arenas. Firstly, market authorization, how drugs or cell therapies get into the marketplace through various authorization processes, safety testing, trials and so forth. But secondly, and perhaps less often talked about, gatekeeping that's operated through health technology assessment processes, and in the UK by organisations like NICE, National Institute for Health and Care Excellence, which, if you like, polices entry of products, regenerative medicine products, into the healthcare system itself. So two rather separate forms of gatekeeping, I think. What I'm going to do in the talk is, firstly, I'm going to skate very briefly through some ideas about classification, which I think are very important in the regenerative medicine field, because the field is extremely diverse in terms of types of procedure, types of product, types of cells, as we were hearing earlier on today. And so a key question is how gatekeeping, how regulation is able to cope with the incredibly complex classification of different types of product. The background, I have to mention that I'm drawing on various ESRC projects here, so thank you to the ESRC, in at least 4 different projects, one of which is led by my colleague Brian Salter at KCL, and a colleague, Sahidi Datta, is just sitting over there, who works also on that project. And a third project just starting, led by Andrew Webster at York, which also involves my colleague Aurelie Mahalachimi, who's also sitting just there. So I know I'm amongst many anthropologists, so I have to say that this is a sort of top-down focus that I'm taking here, and I'm looking at high-level governmental gatekeeper institutions at national level and above, transnational level, and the sorts of methodologies that they use in making market authorization or healthcare adoption decisions. Some very basic starting points conceptually. I see regulation or gatekeeping as itself an innovative process, a performative process, not only in terms of shaping particular parameters that products may take, but also in shaping the whole field of regenerative medicine, which clearly has become highly politicized. Stakeholders compete, but when we're looking at the development of new aspects of gatekeeping or new regulations, there's always an inherited regulatory field there, which can be very inert and impervious to change. So as I said, I briefly mentioned some ideas about classification, which I think are very important. I mentioned this one, not least because it comes from an article about wine. The way that classification works is that it confers identity on the different types of social actor involved. It creates social boundaries that signify the social standing of different actors, and inevitably it involves political struggles. I particularly liked some work by the law academic Roger Bransford, who talks about the regulatory problem with new technologies in terms of regulatory connection. How does one maintain connection between gatekeeping or regulatory regimes and the diversifying, innovative technological process? I'll come to that, back to that idea later. And so that idea can also be described in terms of commensuration. How are goods in one place made similar to goods in another? And Donald Mackenzie from Edinburgh has also written about this in terms of the politics of market design, where he was actually looking at the carbon trading marketplace. So, like classifying different forms of mushrooms, classifying different forms of regenerative medicine is very complex. But I think what I've observed in looking at the sorts of regulatory processes and regulatory innovations that have happened is that bringing different types of technology together under life science policies, regenerative medicine policies, or in Europe, advanced therapy, so-called policies, is that inevitably produces a sort of proliferation of different sorts of institutional discussions, working groups, so on and so on, which, because problems are continually sort of recreated. And the advanced therapy and medicinal products regulation in Europe is an example of this, which brought together somatic cell therapy, tissue engineered products, and gene therapies. So I've said that. So what I really want to talk about is the idea that there are various sorts of exceptions and exemptions that have been created over the last few years to what are the dominant gatekeeping regimes. So in that context, is regenerative medicine being turned into a case, if you like, of special treatment from a gatekeeping point of view? And is it possible to maintain regulatory connection while this sort of technology is evolving and gatekeeping regimes try to deal with those innovations? So turning to what the first form of gatekeeping of market authorization, as long ago as 2006, a range of licensing flexibilities have been available within the pharmaceutical regime. The most used of those is so-called conditional approval, which is being available for products targeting rare diseases. They have to have a so-called orphan designation status, and under various other conditions, approval can be given while extra data is being collected. So it's short of phase 4 clinical trial data under which that can happen. And I believe that between 10 and 20% of all pharmaceutical approvals within Europe over the last few years have actually fallen under that condition, under that route, as it were. Exceptional circumstances licensing can also be used where it's never going to be possible to produce the normal set of data, possibly for ethical reasons. And accelerated approval is also available where extreme public health, such as the Ebola case, public health goals can be proven and agreed by the European Medicines Agency in this case. All those sorts of flexibilities, if that's what they are being brought together now this year under a new initiative from the EU called the Medicines Adaptive Pathways to Patients scheme. And as you can see, the aim of this is that a comprehensive plan of development and exploitation of tools, methodologies, infrastructures that will allow changes in R&D, regulatory and medical practice to enable early patient access to innovative prevention and treatment options is planned. This scheme also includes, which I'm not going to go into, adaptive trial designs, patient-centric benefit and risk assessments, and continuous evaluation, including what the European Medicines Agency has called real-world data. Turning from that, which was the pharmaceutical regulation, to the Advanced Therapy Medicinal Products regulation, which was introduced in 2007 in Europe. Apologise to the lawyers present, I'm not going to go into all the specificities of what the laws are truly called. This regulation, as I said earlier, brought together several different sorts of so-called advanced therapy. The key criterion for the application of this new centralised regulation under the European Medicines Agency is that products should be prepared industrially or manufactured by a method involving an industrial process. The regulation created a centralised system for products meeting criteria under the regulation. It created a new committee for advanced therapies. It gave various incentives, especially to small companies and not to academia. It gave a new pre-certification facility, which is hardly being used for small companies, introduced risk management and various quite potentially stringent post-market surveillance and very long-term requirement for traceability. So it revolves around mass production of advanced therapy products for allogeneic use and also products for autologous, that's cells taken from the same patient, processed and returned to the same patient. If they are manufactured in accordance with a standardised process, they also fall under the regulation. But that implies, of course, that if they're not prepared industrially, however that's defined, they're exempt from the centralised process, and this is called the now quite infamous hospital exemption. How is that hospital exemption interpreted? I mean, the definition of it is that a medical practitioner must prescribe a particular product within a particular hospital for nevertheless within the same sorts of standards that the centralised process sets up. So the MHRA, the regulatory agency in the UK, is looking at this, the operation of this very closely, as are other regulatory agencies. They want to know whether it's the same product repeatedly used that's being considered. It can be very difficult to define, and what's the scale and frequency of that. And we know that different regulatory authorities in different countries in the EU are interpreting this scale of use in rather different ways. So we're seeing a form of exceptionalism here that the European Medicines Agency is setting up, I think, in particular related to stem cell products. They say to date, well, they said in 2010, no stem cell medicinal products have received marketing authorization in the EU. However, it's still possible to gain access to them under certain controlled conditions. This includes compassionate use programs or a custom-made medicine as part of the hospital exemption. This is a situation that the European Medicines Agency is quite concerned with and has been one of the major topics of the public consultation over the last year. In fact, they're worried, as this quote shows, that the hospital exemption may allow relaxing of the safety criteria and risk criteria that they think ought to be applied. So that was looking at the pharmaceutical gatekeeping and the advanced therapy gatekeeping. I now turn to look at the second mode of gatekeeping, which is the policing of access. Can't read that.
2 minutes.
Okay. Which is the policing of access to the healthcare system. The background to this in the UK is a life science strategy which was launched by the Prime Minister a couple of years ago, and the House of Lords Science and Technology Committee, which produced a report on regenerative medicine in 2013, which takes a sort of bioeconomy perspective, i.e. it's not only interested in health goals, it's also interested in economic goals for the UK. In looking at the gatekeeping of the UK healthcare system, there are two main institutions of interest. Firstly, NICE, which is the National Centralised Organisation which uses health technology assessment methodologies to examine new products, whether they be medicines, whether they be regulated as medicines, devices, or something else. And then NHS England, which is less well known, which is the national body coordinating essentially the purchasing of healthcare services for the population, but including specialised services, for example, cancer services. So the MHRA, looking at the adoption of new technologies into the healthcare system, has just introduced, after much consultation, early access to medicines scheme, aiming to give patients with life-threatening or seriously debilitating conditions access to medicines which do not yet have marketing authorization. And in fact, they just announced last month that the first HIM designation, that's Promising Innovative Medicine designation,